this is Dr. Kavian Milani for Virginia Medical Updates. One of the most interesting developments in the last few years in the study of diabetes type 2, type 1, and obesity has been the role of the microbiome, the bacteria that live on our bodies in the development of these illnesses. Is there a correlation, for example, between the kind of food that we eat and the kind of weight that we gain? Well, of course there is. That's not news. But the news actually could be that the kind of bacteria in our gut, in our stomach, in our intestines, does determine the kind of disease that we may have, the kind of illness, the kind of diabetes that may develop. And there are a couple of plausible mechanisms for this. If you think about this, really, the bacteria that live in our gut, they do produce enzymes, they do basically have genetic material, so they really can influence the way we become sick or the way we may be able to become resistant to illnesses. And there are a number of studies now that have proven really very interesting results, like in terms of the gut-brain connection, and there's lots of money being put into those kind of studies right now in terms of all kinds of illnesses. Is there a role in autism? Is there a role in ADHD? For our purposes today, though, I do want to focus on the role of the gut microbiome. The human body has about 13 trillion cells, and about 200 to 800 times that number lives in our gut, in the intestines. These bacteria, they grow, they secrete, they help digestion, and they do a lot of things for us. But they also have material that does lead to some very interesting findings. There are a number of studies in which the gut flora, the bacteria from the human gut that is slightly obese, introduced into germ-free mice, and that mice will then develop obesity. Very interesting. And on the other hand, there are also studies of the gut flora from a lean human being being introduced to a germ-free mice, and that mice then remaining lean. So there is definitely a correlation that has been proven in adequate number of studies in terms of the exact nature and the exact connection between gut flora and between illnesses. Looking at the case for diabetes, it is even more interesting because diabetes is an illness that has two types, type 1 and type 2. Some studies have shown that if you introduce basically lactobacilli or acidophilus to children that are basically 1 month old, you will see a decrease potentially in type 1 diabetes. That's a very interesting finding. But there are also studies of the same nature for older people, older subjects with diabetes, where if you have people that they have the appropriate type of good bacteria in their gut, the Bacteroidetes species, these group of bacteria, they do cause a decrease in insulin resistance, they do cause a decrease in weight, and they do cause a decrease in ghrelin, the hormone in charge of appetite stimulation. So there are a number of places where this could be used. But the most compelling and the most interesting data comes from rat studies, where a rat is subjected to increased caloric intake, and the type of gut bacteria that is more suggestive of obesity and weight gain goes up in these rats. And then when that rat is given new kind of bacteria, the obesity actually goes down and the rat becomes lean. And so this is very, very good evidence that between the gut flora, the bacteria that lives inside of us, and the particular situation with diseases like obesity, there's a direct correlation. So one of the things that may be coming out in the next couple of years is the use of bacteria to help to fight obesity and fight illnesses. One of the interesting things is the Firmicutes bacteria that are basically known to create a condition of insulin resistance, of weight gain, and of increased caloric absorption. So for example, if someone has a preponderance of this type of bacteria, they may eat some food and more of that food then is broken down, converted to calories, and is actually absorbed. So that's correct. Two people may be eating the same kind of food and one will gain weight and one will not gain weight. And the gain in weight has to do with the relative ratio of these particular bacteria in the gut versus the bacteria that cause kind of lean approaches in the gut. So there is a lot of research that's going to be going on here. In short, as far as the clinical approach is concerned, there is no medical recommendation at this point, but definitely if one is taking antibiotics, I would suggest taking yogurt for a prolonged course after that. I think a daily course of yogurt can be very beneficial and exceedingly useful. And there should be definitely, we should keep our eyes open for studies that will come out in the next couple of years that will guide us in a direct direction. But at this point, I think it is very, very prudent for people to begin to be taking more lactobacillus, more acidophilus, more yogurt, and basically more things that do have and do contain live bacterial cultures. And these are, I believe, going to be proven very, very useful in the next couple of years. The most important thing for us to remember is that at this point, there are no randomized trials that show that there is a direct benefit on diabetes or on obesity. But what the revolutionary way of thinking here is that this could be potentially a paradigm shift, could really rearrange the way we think about diabetes, the way we think about obesity, and why people react so differently when given the same amount of food. One interesting study that I did cite above is that when the flora of a person who is obese is given to a mice, that mice then follows and becomes obese. And when the gut bacteria from a person that is lean is given to a germ-free mice, that mice then becomes lean. And it's interesting that between these two mice then, the lean bacteria are more dominant. So if these basically live in the same environment, gradually all the mice become lean. So in general, this is a very exciting and a very new approach and a very new way of thinking about obesity, weight gain, and diabetes. And we should really be ready to receive some more information. And as more data comes out, we'll be happy to share that data with you.
Welcome to Virginia Medical Updates. My name is Alejandra Gonsalves, and today we're here with Dr. Liana Abramova. Welcome. And this is just a reminder to let you know that our program today is sponsored by Virginia Family Medicine. Virginia Family Medicine integrates functional and alternative medicine in their practice to complement their expertise in medical care. Their areas of focus are in preventative medicine, holistic health, and weight management. So Dr. Liana Abramova has a medical and cosmetic practice in Fairfax, Virginia. She has been in practice for over 15 years. Originally from the former Soviet Union, she attended UVA for her undergraduate studies and Emory University in Atlanta for medical school. After she finished her residency at Washington University in St. Louis, she returned to Virginia to be with her family. She has authored several articles on melanoma research and is an active member of the DC Dermatologist Society. Dr. Abramova has special interest in prevention of skin cancers and general dermatology. And our topic for today is hair loss. So thank you, Dr. Abramova, for being here again. It's an honor to have you here with us. And talk to us a little bit about hair loss. How common is it in the general population?
Well, I see hair loss in my clinic patients every day. I think at the end of every visit that I have, at least a few times a day, somebody asks me, oh, by the way, can I ask you a question about my hair? I've been shedding and I've been losing quite a lot. And whether a patient truly experiences hair loss or they just experience a normal amount of shedding, it always comes up as a topic. So I think it's one of the most common things that I see in dermatology, and I see it in both adults and I see it in pediatric patients as well. There's different types of hair loss that one can experience.
Okay, and talk to us a little bit more about that. What are the differences?
Yes, so it just depends. There's two types of hair loss that we usually look at. There's scarring hair loss and non-scarring hair loss. And when we talk about scarring hair loss, and when you see a little bit of redness around each hair follicle, so when patients examine their own hair, they'll see that around each hair follicle there was a little bit of redness and a little bit of inflammation. That type of hair loss is really uncommon, but if diagnosed early, it can be corrected. There's non-scarring hair loss, and those are usually androgenetic alopecia, alopecia areata, and telogen effluvium. Those are more common types of hair losses, and that's what majority of my patients presented with. Androgenetic alopecia is something that you see in both males and females. Female pattern hair loss, when you see a lot of frontal thinning, that's what you notice in one patient. And then male pattern hair loss, that's so common. We probably see it in majority of our patients, male patients by age of 50, some type of thinning of the hair. In children, it's usually alopecia areata, when hair just falls in big patches, and they will present with like 1 or 2 of those oval patches on their scalp. And then telogen effluvium, that's when you shed a whole lot of hair. Especially happens right after somebody had a baby, or they had stressful episodes in their life, they've been sick, they had experienced hospitalizations. So those types of hair loss are associated with telogen effluvium. And that's when you notice a whole lot of hair in the shower, and you see it in the corners of your house, and you're like, oh my God, what's happening?
So what type of treatment can be done for someone who does come in and say that they have this going on?
So it just depends. First thing that we probably need to do is figure out what type of hair loss they're experiencing. And so I usually order some blood tests initially, and just to check their iron levels, their thyroid tests. So
you got to find the source
first. The source, like we order the estrogen, progesterone level, testosterone level, just to make sure nothing is out of normal. And once we do that, sometimes I offer patient a biopsy, because sometimes even if the blood work is normal, you still need to figure out why they're losing so much hair. So we do a small biopsy of a scalp and get to the bottom of it. And once we sort of figure out what's the diagnosis is, then we can proceed with a treatment.
And so the treatments, what range of treatments are there? Is it just a medication that someone can take?
Treatments are sort of like, it tailored to every individual patient. Every patient deserves their own look. So sometimes we offer just minoxidil, which is Rogaine. And everybody heard about Rogaine, but everybody's sort of scared to use it. They're like, oh my God, but once I start using Rogaine, I'll be on it forever. And I say, well, what's the alternative? Sometimes we just have to start using it early enough so we stop shedding.
Now, Rogaine, is that over the counter? Or
it is over the counter treatment, and sometimes it's recommended in some of our alopecia patients. Other treatments are a little bit more like prescription medications. And that would be for hair loss in males, we prescribe Propecia. And Propecia is a medication that blocks the conversion of one testosterone to more active form of testosterone, which sort of results in more aggressive hair loss. So Propecia is one of the pills that we can offer to our male patients, but never to our female patients.
So the females don't have an option to take that.
I mean, I think that they can, as long as they're not planning to get pregnant anytime or ever, because it's such a teratogenic medication, meaning it causes severe birth defects.
I see,
For females, there's a pill called aldactone, spironolactone, which is an old blood pressure medication, but it's also sort of anti-testosterone medication. Once again, should not be taken when one is planning to get pregnant. But if there's no such plans, then it can be safely taken and carefully monitored. There are few side effects that are associated with both of those medications. So we do have to sort of do blood work before we start those medications and monitor them carefully while they're on it. I do also refer them sometimes to primary care doctor to get the blood work done, and sometimes just to see if they're good candidates for it, if there are other multiple medications. Sometimes we inject steroids to help with our scarring alopecia. Sometimes we apply topical steroids for our psoriatic patients that are losing their hair, or for our eczematous patients that are scratching a lot. And you know, there's have been a lot of talk about lasers in hair loss.
Okay, so this is a new treatment then?
You know, it's sort of been around for like past 5-6 years, and FDA has not cleared it completely yet. They nodded to some of those lasers, but they've not said, oh yes, they absolutely work. So when I recommend somebody to get any type of hair devices for their laser devices for their hair loss, I sort of say it with hesitancy because I don't know the full impact of it, and I don't know if they're going to deliver the promise of bringing back the hair. So I'm very careful. So, and I do want to mention one last thing with the newest and the latest, which you hear a lot about in our news with hair loss, is a medication, is injectable called PRP. A lot of people use it for treatments of other disorders, plasma-rich platelets. And what they do is you get a little bit of blood out of patient's veins. You just get a little bit of blood, and then you spin it and inject it into the scalp. And that's supposed to promote hair to regrow. Once again, it's a little bit controversial because there's not a lot of study which show it's completely beneficial. There have been a few, and a lot of dermatologists are starting to look into it and to start doing it. It's always out of pocket, so it's always hard to say, go ahead and spend all this money on doing it, because there has never, well, I don't want to say never, there's not been conclusive research studies which show that it works well. Okay,
but this is the plasma that's causing or enabling the hair to grow where it is working for patients.
Exactly, those platelets really have lots of growth factors in those, and whenever they get delivered directly to the hair follicle, they promote the increased growth of the hair.
Okay, so interesting. That's very interesting. Okay, so maybe we'll see going forward if the FDA will approve that and see if that's something that patients will have an option.
Yeah, it's all off-label now, but I'm really excited to see bigger studies that are done with PRP to see if it really works.
Okay, and then what about someone who's trying to go maybe the natural route? Are there any types of options for them if they don't want to do medications or any type of procedures?
You know, a lot of people ask, what about vitamins? What about hormones? What can I do that can naturally increase my hair to grow? And you know, there's no known vitamin that causes the hair to grow back. A lot of people spend a lot of money on biotin.
Yeah, you see a lot of advertisements
yes,
for
like
that.
Biotin for nail and hair growth. But once again, biotin is has never been proven to be helpful for hair loss. Because majority of us are not deficient in biotin. As long as you're, not pure vegan, I think you're okay. But if you want to supplement, it does not cause any significant problems increasing your biotin intake. Of course, it's good to maintain healthy diet. I think it's really important to eat well and increase your protein intake, especially if you are vegetarian. Take just for our females normal prenatal vitamins, because sometimes we become deficient in iron and folic acid, and it might increase some of the hair to come back. But once again, never been proven that any of those vitamins help regrow the hair.
So it might maybe strengthen or maybe prevent, but obviously if it's an issue that you're really having with alopecia, it's best to come and see you or see a dermatologist that can help you.
And especially for our scarring alopecia, the sooner we diagnose them, the better it is, because some of it could be related to the products that patients are using. Sometimes it could be related to the styling processes that they're doing. If we do a lot of relaxers, if there is lots of heat and flat ironing the hair, it can cause breakage and damage to the hair as well. So the sooner it's recognized and diagnosed, and the sooner it can be stopped, and we start injecting steroids or doing topical steroids, the better the outcomes will be later on.
Okay, great. So thank you so much, Dr. Abramova.
Thank you for having me.
It's been really great to have you here.
Pleasure.
And we've learned a lot today. Thank you for joining us here at Virginia Medical Updates. My name is Alejandra Gonsalves, and we'll see you again next time.
Hello, this is Dr. Kavian Milani for Virginia Medical Updates. Today we'll be discussing the very important topic of osteoporosis and screening for osteoporosis. In general, osteoporosis is an important disease causing a lot of morbidity and a lot of mortality in the elder population. The recommendations at this time are to screen all women at the age of 60 and above about every 1 or 2 or 3 years, depending on the risk factors. And for men, the screening may begin at the age of 65. And again, this can be modified based on their risk factors. Well, what are these risk factors? Well, the risk factors are the use of PPI, proton pump inhibitor medications, like omeprazole, Prilosec, chronic steroid use, and low bone and BMI. So basically, if you have low BMI, there are smokers, and if there's any history of prolonged use of steroids, like in asthmatics or people with skin conditions, then it's prudent to start screening a little bit earlier. But the general rule of thumb is at the age of 60 for women, at the age of 65 for men. Now, in general, osteoporosis affects women more, but it does affect men also significantly. So at the age of 50, we begin to talk to our patients about risk factors and we begin to screen them for osteopenia, for osteoporosis, and for these risk factors. Remember that once a hip fracture occurs, and that is definitely the thing that we want to avoid in osteoporosis, when a hip fracture occurs, then basically this now has a prolonged hospitalization, a very dangerous surgery, risk of blood clots afterwards, and about a quarter of the patients may not be living at the end of 1 year. So this is a process with a significant amount of morbidity, like blood clots, like surgery, like prolonged bed rest, bed sores, and actually a high death rate. So in general, we do want to prevent and screen for osteoporosis when we can. The osteoporosis also needs to be treated in the population of people that are at risk by adequate exercise, and in general, weight-bearing exercises are what people need. So it is really important to begin a program of, for a prolonged period of time of weight-bearing exercises. Also, fast-paced running, treadmill, stair, these things are all beneficial, but also weights and resistance training at the hip and spine are actually also very, very useful. Then, of course, calcium supplementation. The current recommendations and the best evidence suggest a calcium intake of 1,000 to 1,200 milligrams per day. And that amount of calcium can really begin to help the bones maintain their normal strength. So calcium, number one, and weight-bearing exercises as number two, and to this has to be added vitamin D. Vitamin D is a little bit more difficult to ascertain, but about 800 IU of vitamin D3 or D2 per day is what the body needs to have the calcium work better at the bone level and to create a stronger and more cohesive bone. A bone that is better resistant against fractures in the case of a fall. There are a number of studies that do show that a multiple of drugs actually do help with the bone marrow density, the BMD. So basically, there are a number of drugs that work and are pretty effective. Remember that we are trying to really prevent the one fracture is the hip fracture. All fractures of rib, for example, or of long bones and the spine are, of course, uncomfortable and are bad. But there's really no correlation like between rib fractures or skull fractures and the BMD. But the long bones and the hip bones are most susceptible when the BMD begins to go down. So we do want to make sure the bones are remaining strong. How do we maintain these bones that are strong? Again, by calcium supplementation at 1,200 milligrams per day, vitamin D of 800 per day, and the use of exercise. There are a number of drugs that have been approved, and 4 medications come to mind that we'll discuss at a later time, but do help people maintain bone strength. So once the BMD begins to go below 2.5, then these medications are used to actually bring the bone marrow back to the correct density. One more thing is that when we look at these studies, the focus has to be on, and I repeat this, on hip fractures. A lot of studies have been done on a lot of drugs that do show improvements on spine fractures or on radiographical spine findings. But these are not really clinical findings that people are concerned about or they should be concerned about. So a radiographical finding on the spine is important, maybe as a prelude to other things, but a weakening of the bone at the hip or the femur is really where we want to identify the problem and intervene as soon as possible. So for anyone that approaches the age of 50, I suggest, again, screening carefully by questionnaires and by medical questioning. Make sure everyone is on correct amounts of vitamin D and on exercise and on calcium. And with this combination in place, at some point, we begin screening using bone densitometry. The people that need to be carefully looked at are women who have been on steroids or have used PPIs. And one interesting finding is that actually the thiazide diuretics like chlorthalidone or HCTZ have been proven to actually improve BMD and potentially cause less fractures. So that's one class of antihypertensives that we could use that actually helps to have stronger bones and potentially decrease the rate of fractures. So osteoporosis is the end product of this process of the weakening of a bone that begins. Our screening for the issue begins at the age of 50 and for at-risk populations. But we really must be very focused for anyone that is a woman at the age of 60 and for men at the age of 65. And then in order to prevent these, again, I'll repeat, calcium intake, exercise, and adequate vitamin D supplementation. With these things in place, then we can screen the appropriate population and treat them when indicated or when needed to prevent the unwanted outcome of a hip fracture. Hopefully, you've enjoyed this session and have learned something from this. We're able to talk to you guys if you want to, and feel free to contact us on our Facebook page or through email. Thank you.